Let's take a closer look at this case. We have selected axial views from a CT scan of the brain, captured pre- and post-contrast. There's a notable extensive low attenuation area within the white matter of the right frontal lobe, characterized by an ovoid area internally that matches the attenuation of gray matter. This lesion measures several centimeters in diameter and shows peripheral enhancement following contrast administration. There's a significant mass effect with effacement of the frontal horn of the right lateral ventricle and a midline shift to the left by approximately 1 centimeters. Given these findings, my next step would be to review the remainder of the study, particularly focusing on the cerebrospinal fluid spaces and paranasal sinuses, to check for further lesions. The preservation of cerebral parenchymal volume suggests that this is a younger patient, which is a useful detail to note. In summary, what we're seeing here is an apparently solitary lesion in the right frontal lobe, surrounded by hypodensity consistent with vasogenic edema, accompanied by a mass effect. The differential diagnosis at this stage is largely dependent on the clinical presentation. If the patient is relatively young and exhibits symptoms such as pyrexia or sinusitis, I would lean towards a diagnosis of a cerebral abscess. This is especially the case if the patient is generally well, as primary brain tumors can also present similarly. However, if there's a known primary malignancy elsewhere, this finding would raise the suspicion of a metastatic deposit. The lesion's wall is generally thin and points towards the ventricular system, suggesting the possibility of a cerebral abscess over other conditions. Nevertheless, regardless of the suspected diagnosis, this case warrants an urgent discussion with the neurosurgical team. If diagnostic uncertainty remains, further imaging with MRI, particularly diffusion-weighted imaging, DWI, can be crucial for narrowing down the differential diagnosis. The subsequent MRI images show a lesion in the right frontal lobe, displaying low signal on T1 weighted images and surrounding vasogenic edema. The lesion enhances on post-gadolinium images, indicating true enhancement rather than artifact. The frontal horn of the right lateral ventricle remains effaced, and both DWI and ADC mapping show restricted diffusion, which is more indicative of an abscess than a tumor, although some tumors can present similarly. To reiterate, the diagnosis here is a cerebral abscess in an 11-year-old. This conclusion is supported by the clinical and imaging findings, particularly the presence of restricted diffusion and enhancement patterns typical of an abscess. In such cases, it's critical to consider the wide range of differential diagnoses, from abscesses to primary or secondary tumors, demyelination, infarcts, and more. The clinical context is paramount for accurate diagnosis. For example, if a patient presents with fever and sinusitis, abscesses are a strong consideration. In contrast, if there is a history of known malignancy, metastasis becomes more likely. Imaging findings like thick-walled ring enhancement and diffusion restriction can help distinguish these entities, but additional diagnostic tools like spectroscopy might also be necessary. In summary, cerebral abscesses are a critical differential diagnosis to consider when evaluating ring-enhancing lesions, particularly given the potential for serious complications if not treated promptly. In this case, the imaging findings and clinical context strongly suggest an abscess, underscoring the importance of a thorough and methodical approach to diagnosis in neuroradiology.